जितू सर
जॉईन झाले.
विक्रम लाईव्ह झाला का?
येस. हा,
live on YouTube.
Good evening all. Welcome friends. We have again started the webinar. There is a break in between. So welcome on behalf of Navi Mumbai IIP and Department of Pediatric MGM Hospital Kamote on this wonderful newborn week now. We are starting on the 50th. We are started on 50th with the activity of how to care a newborn at home by Dr. Suresh Biradar. Then today we are taking a activity on NICU rounds. Why it is important? Because if these rounds are taken properly, then only the child can be sent home. And for this session, we have got a wonderful faculty with us and wonderful, I would say, participants like Dr. Jay and many more. So I welcome and hand over the mic to Dr. Jitendra Gavane sir, who is our President Navi Mumbai IIT. Jitu sir.
Dr. Bansode, can you mute yourself?
विक्रम म्यूट करून घ्या ना सगळ्यांना एकदा. म्यूट विक्रम.
So, on behalf of IIT Navi Mumbai and MGM Medical College Navi Mumbai and DY Medical College Navi Mumbai, I welcome you all for celebrating the
सर मी एक फोन करतो त्यांना, 1 मिनिट फक्त.
म्यूट कसं करायचं मला जमना झालं.
होस्ट नहीं किया ना उसने, होस्ट विक्रम ही है सिर्फ.
कॉलेजमध्ये पण फोन घ्यायला याला काय झाला करायची गरज नाही.
कसं काय?
हॅलो विक्रम. हॅलो.
कुठं म्यूटचं हे आहे का?
Sir, please. Jitu sir.
Yeah.
Yeah, please start.
For interruption, good evening friends. On behalf of IIP Navi Mumbai and MGM Medical College, DY Patel Medical College, I welcome you all. Friends, we are celebrating the newborn week this time in November. And as a part of various activities, today's webinar is arranged. Friends, for today's webinar, we have special guest, Dr. Rajesh Rai sir. Dr. Rajesh Rai sir needs no introduction. He is a head of the department and very active member of IIP Navi Mumbai. He is heading the department since last 19 years. I welcome you, sir, and request you to say a few words.
Hello, everyone. Anyway, I'm attending this meeting for the very first time for a simple reason, because of a lot of things were going on at our place at DY Patil, and those were nothing but the inspections related to NMC, then inspections related to NAC and all those things. But I think better not to talk about those things and going into retro mode. But we have to talk about the newborns. And as always, we celebrate newborns every day. It's not limited only to a week or a month. And our aim, in my opinion, should be that we should always think about our future generations, especially the newborns, and try our level best to bring down the neonatal mortality rate to the minimum possible. It is targeted to be in the single digit, but I think we are not far away from this. And we at our ends, be an institution or a private hospital or anywhere, we as pediatricians, we leave no stones unturned to do that. And we can very well say that Navi Mumbai Academy of Pediatrics is proactively participating in all these type of activities, and that is reflected in our work as well. If you look at the figures about the neonatal mortality rates as compared to the national figures, Maharashtra stands pretty good, in pretty good shape. And I don't know exactly, but if we see the figures of Navi Mumbai, if you can get it, I didn't find it anywhere. But I think it would be even better from other parts of the state. So I wish that the efforts, the time given by pediatricians, the academic activities being taken, and whatever efforts we can put from our end as a pediatrician, as a neonatologist, I think it is reflecting in the society as such. So I wish all of you all the very best of whatever actions we are doing, and we have to keep it up. Thank you so much.
Thank you very much, sir. Thank you for gracing the occasion. Friends, today we are going to discuss grand rounds in NICU and practical tips we are going to get from expert. To moderate today's session, we have Dr. Sheetal Kolle, madam. Madam is a professor in neonatology in DY Patil Medical College, Navi Mumbai. I welcome you, ma'am, and I request you to introduce the speaker and start the session. Thank you.
Good evening, sir. Today's speakers for this session is Dr. Om Prakash. Dr. Om Prakash is in charge of neonatal services at Apollo Hospital. And second panelist is Dr. Piyush Jain, sir. Sir is in charge of neonatal services at Cloud9 Hospital. I know sir since KEM days. I worked under him. I don't know whether he remember or not, but we know each other since long. So we, without further ado, shall I start with the cases?
Yes, sir. Yes, ma'am. Only GR we can remember, not all.
Okay. Dr. Vikram, you might have to enable me to start the screen share. Dr. Vikram?
Vikram? Just a minute, I'll just call in.
Yeah.
Dr. Sheetal, along with you, Dr. Om Prakash was also there at KEM.
Yes.
He was doing, I think, his senior residency at that time when I was doing my DM neonatology from KEM.
Yes.
Oma. Oji, yanda kanla ivlo thookom.
So now I think with the help of Rajesh Rai sir, you should start thinking about starting some DNB or TM
Yes.
neonatology program at
Yes.
DY Patil.
True.
Big institute and very good, big, large NICU. Lot of cases.
So first we are planning, actually fellowship program is going on, but then still we have not enrolled anyone. So first we are planning to have fellows, and then later on it will be planned for DM.
Yeah.
Rest all can mute yourself. Ma'am, please to make the parat try kare.
Oh, yes. Sir, host disabled participant. Not yet happening, sir.
Last time
एक मिनट कर
वैक्सीन नहीं दे सकता
Okay. Not happening.
ड्रॉप बंद करो तो एंटीबायोटिक को बंद करो.
Okay. Okay.
क्रीम वही लगाओ. नाक में डालने वाला ड्रॉप है क्या? बुखार का दवाई. टाइम ले लो मैम. अब तो उस दिन गाड़ी पे गए ना।
नहीं, वो तो सर काफी दिन पहले की बात है, हमने फीवर की दवाई लिख के दी थी ना। जब
वो
सर्दी हुआ
दूसरी
था।
वाली थी रहमत
वो दूसरी वाली थी, तो आपने बोला था अगर लगेगा तो ले लेना, तब से उसका दिन फीवर आ गया थोड़ा सा शाम को। चलिए सर, थैंक यू।
बाय बाय।
Sorry for the interruption. Only 2 minutes. He's handling with the other device now.
Okay, sir.
आता इधर try करा.
Yes. Now.
You can share now. Huh?
Raise partition. Mute झाले. You can start now.
Yeah.
Sorry for the interruption.
So, yes. So let's begin with our first case. Wait.
काय problem येते चित्ते मॅम?
Yes, I'm not able to make the forward slide.
तुम्ही एकदा exit करून परत ते करा.
I'll do it. Okay.
Yes.
Yes. So let's begin with our first case. So baby of A, DCDA twin 1, that was female baby born to primigravida mother, not covered with antenatal steroids, and born by section because PROM for 8 hours was there. It was product of IVF conception, 29 weeks by scan and by date, with birth weight of 1250 grams. Then baby cried immediately, not required any resuscitation, but baby got intubated in view of respiratory distress. On examination, we found that baby is pale with tachycardia, CRT of 3 seconds, and RD was persistent. Baby, as usual, was intubated and given surfactant within half hour of life. So after giving surfactant and after ventilation, pallor was still noticed. Tachycardia was persistent, though RD was settled because of surfactant and ventilation. So we sent routine investigations. In routine investigation, both mother and baby were A positive, and HB was found to be 6.2 with normal counts and platelet 130. Then we sent for the another twin, which was male child weighing 1210 grams with hemoglobin of 16 and platelet of 149. On inquiry, mother platelet were 160 with HB of 11.3. So it was severe anemia. So Dr. Om, I would like to ask you that what are the causes of severe anemia at birth?
So anemia is a very common condition that we see in neonatal age group, particularly babies who are staying with us for a longer term, less than 1 kg. At some point of time, they do get transfusion. But in this situation, here we saw a background of twin babies, almost same weight. That is another important factor for us to understand. And they are having, one baby is having hemoglobin quite severely low, 6, and then other is having near normal hemoglobin. So here, there are possibilities. What we need to think of is the acute blood loss. Okay? So either there is a problem with acute loss of the second, there is problem related to the destruction of the red blood cells, or there may be problem related to the production of the hemoglobin, production of the red cells. So now loss in a newborn baby can happen at any level, at any stage. So let's come from the placental end. There may be retroplacental bleed, there may be fetoplacental or fetomaternal bleed, or there may be bleeding at the internal organs, like there may be IVH is another common injury that we can see on day 1 of life, extremely preterm baby who has not received steroids. So that is the loss that can contribute for the low hemoglobin at the time of birth. Next is related to the destruction of RBCs. We know RH incompatibilities can present at birth with hydrops and anemia. But here, the baby is externally looking fine. There are no any signs symptoms of hydrops. So hydrops is not looking like the primary cause. Okay? Minor blood group incompatibilities causing this sort of lysis is very unusual, particularly at the time of birth. And even enzymopathies presenting like this is also not so common condition to think as a primary injury. And then production problems, aplasias, if there is aplastic marrow failure or all that things, or congenital parvovirus infections or torch infection can also sometimes present with anemia. So these are a few things that we should keep in mind, and then accordingly we need to investigate to find out the cause for anemia for this baby.
As this, there were gross discrepancy between the hemoglobin of one baby and another baby, almost 10 difference. So can it be a twin-to-twin transfusion in this case?
I did mention about that. See, if there is twin-to-twin transfusion, there will be discrepancy in the hemoglobin as well as weight of the babies. So one is donor and one is the recipient. Even though it is BCDA twins, there are possibilities of having twin-to-twin transfusion that we need to keep in mind. But provided the background, like they are almost same weight, otherwise they are fine.
Yes.
So the chances will be less. So here I will say there may be some loss. Maybe there is the placenta previa, abruptio placenta, retroplacental clots, or some fetomaternal bleed or something like that. That is more in line.
Yeah, there was no history of any blood loss during pregnancy, as you mentioned. And second thing, let's now, Dr. Piyush, how we are going to evaluate this newborn and make a differential diagnosis in this case.
Thank you, Dr. Sheetal. So basically, this is a preterm baby with significant anemia. So our evaluation should start right from, as we have understood from our UG teachings and PG teachings, that we should not miss any history and physical examination. So we should go back to our obstetrician colleague and ask about, as you already mentioned, there is no significant bleeding, but we should double check, especially any retroplacental clots or any evidence of acute blood loss during the time of labor. Sometimes we are busy in resuscitating the baby and we don't have enough time initially in the labor room to assess whether there is any loss. So we should always ask with our obstetrician. And then next is our detailed physical examination. So for any losses part, we can have like cephalohematoma or any bruises or any obvious bleeding from the baby, we can assess during our physical examination. And then comes the main role of lab investigations. So lab investigation, as you have already mentioned in your case presentation, so basic tests remain same, like we have to do a good CBC to understand other cell lines along with hemoglobin, whether the other cell lines are also depressed. Then detailed peripheral smear that should give us idea of any congenital issues like hemolytic disease, spherocytosis, or any membranous defect in RBC. And then reticulocyte count will help evaluating any ongoing losses or the chronic anemia. The reticulocyte counts will be raised. And as Dr. Om Prakash said, RH and ABO incompatibility. So for that, we should do a DCT and ICT test to assess whether there is any hemolytic changes going on. And for finally, for internal bleeding like IBH or adrenal hemorrhage or any intra-abdominal abnormal bleeding, which is although not very common, but to complete the list, we should do a USG abdomen to find whether there is any loss. And finally, sepsis, as we all know, can present with any symptoms. So simultaneously, we should rule out sepsis, whether there is some severe sepsis which is causing, although unlikely to cause so severe anemia. But yes, we should always keep eye on the sepsis part. So a detailed history, physical examination, and lab investigation. So that's how we should go ahead and try to find out what are the common problems there. Then obviously some rare cases, we have special tests like AP test and KB count if there is a feto-maternal hemorrhage. So if there is any from baby to mother, if some bleeding is happening, so maternal investigation in the form of KB counts we should.
Yes. So basically, we did all this investigation where retic was normal, USG skull was normal. We scanned for USG abdomen, and all these investigations came normal. So, and no history, of course, as I mentioned earlier, there was no history of bleeding per vagina or retroplacental clot in the mother. So, yes, we did serum bili to rule out hemolytic cause of anemia, which turned out to be normal. It was on day one, it was hardly 3. So it was insignificant. So in this case, as you correctly mentioned, we suspected some feto-maternal hemorrhage. Hydrohospitalis antenatally, there was no diagnosis of any pleural effusion, and we did later on also USGs to evaluate this. There was no third space loss, as well as with this, we diagnosed this, and then we sent the Kleher-Betke test, as you correctly mentioned. So this result was 5%, and this was sent to ICMR, immunohematolog in KEM, and it turned out to be 5%. And we found the cause of this. So I just want to know that what are the other indication of this test, Kleher-Betke test? Dr. Piyush.
So Kleher-Betke test, as you mentioned, is a marker for basically we suspect when we have other baseline tests are all negative and we are unable to pinpoint the cause. So since it's a specialized test and it should be done on the mother's blood, so it helps us in diagnosing whether there is a bleeding from a fetus to mother in utero or during perinatal period. So it is helpful for diagnosing the rare causes where we are unable to find out the exact cause. And this test utilized the special property of fetal hemoglobin. As we all know from our biochemistry classes, fetal hemoglobin is resistant to acid. So that property is utilized, and the maternal smear is stained with, first the smear is cleared with acid so that all maternal hemoglobin is washed out. And then when it is stained, the fetal RBCs can be visualized and the maternal cells will just appear as a ghost cell. So that will give us an idea of the number of fetal cells. And as far as I remember, every 50 ml of fetal loss will show 1% increase,
yes.
1% count in the mother cell. So as per your report, like 5% maternal, 5% fetal cells in mother circulation, that roughly shows around 250 ml of fetal loss, which is almost almost 90 to 100% of that baby have lost. So probably it's a very significant blood loss from a fetus to mother. So it does help in diagnosing the rare causes of fetal anemia.
And definitely we have to send this test within 20. Actually, we have to send maternal blood, and that too also less than 24 hours.
Within first 24 hours.
Yeah, and if ABO incompatibility is there, then this test is little unreliable. Okay, so we'll continue with our case. So we started baby on antibiotics, caffeine and calcium gluconate IV fluids were started. ABG was normal. 2D-CO was suggestive of LVD dysfunction with large PD and pH. So we started with Milry and paracetamol. We gave PRBC transfusion at 6 hours of life because baby had circulatory shock because of this. And with this, I would like to ask Dr. Om that what transfusion guidelines we should follow in the newborn, preterm very low birth weight baby especially.
We try to understand what is the cause of anemia at the time of birth. But subsequently, if you try to analyze, it is anemia of prematurity. This is what we know so far. But I will put it in a different words. It's anemia of phlebotomy loss. So all babies who are less than 1 kg, we tend to do so many investigations, and we all order investigations right, left, and subsequently they do present with anemia. And there are different guidelines that different unit follows. So some people do have a low threshold for transfusion, and some people have a higher threshold of transfusion. In fact, there was a study, there was a PINT study, where they tries to analyze all the preterm babies, and then they look at the threshold of transfusion. Now, this threshold of transfusion depends upon the gestational, the age of the baby, the postnatal age in terms of the weeks, as well as the respiratory support that baby is required. For someone who is in the first week of life, as this baby who has got a requiring ventilatory support and hemoglobin is quite low, so then we need to go for straightforward transfusion. So babies in the first week of life who are on respiratory support, requiring almost like 25-30% of oxygen, it may be a CPAP or a ventilation. If their hemoglobin is less than 11.5, then we need to think of transfusion. And those without respiratory support having hemoglobin of less than 10, we need to think of transfusion. That is one criteria. Second week, if you look in the second week with support of ventilator or CPAP, if HB is less than 10, and without support HB of less than 8.5, and babies who are more than 3 weeks old and more, if they are still requiring, particularly babies who are having a chronic lung disease, who are CPAP dependent, and if their hemoglobin is 8.5 or below, or if they have got a failure to thrive, they are not gaining weight adequately, there are signs of failure. That is also one of the reasons where you should think of giving transfusion. And those who are not having any signs symptoms, but still and not requiring any support, but many times I will say the hemoglobin is less than 7.5. So there was a good analysis in terms of restrictive transfusion and non-restrictive transfusion. So restrictive transfusion means that you wait for the hemoglobin to fall as low as 7 to 8, and non-restrictive means you have a higher threshold of giving transfusion. Like if you even if your hemoglobin is in the range of 9 to 10, then also you tend to give transfusion. So the study that showed that babies who have got a lower threshold of transfusion, they did require transfusion, maybe number of transfusion are higher, but in long-term follow-up, they have got a better Bailey scale. The analysis of developmental analysis showed it was a better outcome for these babies than the babies who are having a low threshold, high threshold of transfusion. If you see the total number of transfusion also in this baby, it was not so significant, and even the hemoglobin difference that was looked for. So in case of a liberal group, they give for hemoglobin of 9 to 10, and in a restrictive group, they give just at the difference at the hemoglobin of 7 to 8. So there is marginal difference, but in long term, there are slight variations in terms of the developmental outcomes. I will say each unit should have got a blood laid down chart. That is very important. That will help us to restrict the number of investigations. Use micro containers like we get a 0.5 ml is enough to do a CBC, as well as similar 0.5 ml is enough to get a liver function test or CRP, so that you take a minimum amount of blood. We do use capillaries to prevent repeated pricks of arterial and venous, and then taking significant amount of blood. So these are the ways that we should help the babies to minimize the risk of requiring transfusion in the future.
Yes. So let's continue with our case. So this baby got extubated, put on bubble CPAP, inotropes we could omit, started feeds on day 8 of life, and we could discharge this baby on day 36 of life. So let's move to our second case. So before this, I would just highlight that simple tests like Leher-Betke test, which are very cost effective, can definitely help us to diagnose cause of anemia. And many times we found that we don't get a cause of anemia, especially in case of acute blood loss anemia in the babies. So let's move to our second case. So baby PK born to primigravida mother. Yes.
Sheetal,
yes, sir.
I have a suggestion. Dr. Sheetal, can I speak?
Yes, sir. Yes, sir.
Hello.
Hi,
Yeah.
yes, sir.
Can you hear me?
Audible. Yes,
Yes.
yes.
Yes, sir.
Yes, sir. We can hear
Can
you.
you
Sir.
hear me?
Yes, yes, sir. You are audible, sir.
Ah. Okay. In this regard, I need opinion of Dr. Om Prakash and Dr. Piyush, because when we resuscitate the baby, most of the time we fail to examine the placenta as such, because we are having many residents, I think, in this talk. So feto-maternal transfusion will take place across the placental lines, is it?
Yes.
Right. Then in that case, whether you have an anemic baby or not anemic baby, as a part of resuscitation, I think residents should make it a habit to examine the placenta and find out the reason. Say, for example, in this case, there must have been some feto-maternal clot or feto-maternal rupture of some blood vessel which have led to this blood going into the maternal side. So rather than going for complicated test, it's a bedside, simple test.
Yes, we agree. I think there's some problem with
Yes.
That make it a habit of examining the placenta and look for the
Very
clots or any of the bleeding, because it may not be evident every time that bleeding and which has manifested. There may be a look for it. And believe me, if you start examining the placenta, you'll find many more things in addition to only this blood clots.
Yes.
What are your opinion? What do you think, Dr. Piyush or Om Prakash?
Yes, that's very important. The examination of the placenta is part of the examination of the baby, and nowadays we ask to the gynecologist, particularly when we are suspecting a case of choriamnitis or anything, have you sent the placenta for evaluation? Many times we get an answer like, no, we have not sent it, we have just dumped it out. So that is very important, that part of your examination is examination of the placenta. That is one thing. And just to add in the list what sir is saying, we should make sure that if baby is hemodynamically stable, we should follow delayed cord clamping, whether it is a term or preterm, because that itself will help to prevent anemia as prematurity, and there are so many benefits that we can think of. And incidentally, we have seen some babies while clamping the cord, they slip off the clamp and then there is acute blood loss. That also we need to be very careful when we are clamping the cord.
Yes.
These are few practical tips. I think sir can share many more like this with his experience.
And
so I think with this case, I think all of us, including residents, must learn, number one, delayed cord clamping and examination of placenta is a must. At least that take-home message they should all.
Rajesh sir?
Yes,
So
sir.
regarding this placental examination, I think it's although it's mentioned in the textbook, but practically most of the times we fail to do it. So in a teaching institute like yours, you should take help from a pathologist as well, because just saying some resident to examine the placenta will not make any change. They should understand what are the findings of a ruptured vessel, how does a clot look like, what are the signs of infection in a placenta. So that only a trained pathologist probably can help them to pick up those small findings. Thank you.
So let's move to our second case. So baby of PK born to primigravida mother, 31 week by gestation with birth weight of 1620 grams. Mother had history of leaking for 8 hours. Baby cried immediately after birth, but as distress was there, baby delivered a labor room CPAP, and baby was shifted to an ICU, required non-invasive mandatory ventilation support. So as usual, septic screen was sent at birth. First line antibiotics were started. Initial septic screen was negative. Day 1, baby had little high sugars, but they got stabilized with dextrose 5%. So baby started on feeds on day 4. He was tolerating feeds, and the settings of NIMV we could decrease. On day 4 of life, it was noticed that baby had mild increase in the work of breathing. peripheral pulses were poorly felt, and mottling was present. So, Dr. Piyush, I would like to know that what are the causes of deterioration in day 4, day 5 old preterm baby who was otherwise fine and for 4-5 days of life?
Yeah, so I think most of us in our practicing neonatology, we come across these kind of cases. So if we see the common causes, most important in our setup still is late onset or the iatrogenic nosocomial infections. So we should always try to rule out infection. Simultaneously, we should work to try to find out any cardiac causes in the form of any PDA or any congenital heart disease. Then other respiratory causes like air leak syndromes or impending or developing pneumonia, which can be there. Then metabolic causes, we should rule out everything like hypoglycemia, calcium levels, electrolyte levels, so to rule out all basic metabolic disorders. And simultaneously, these babies are at risk of developing IVH, intracranial bleeds, or preterm babies. So we should rule out intraventricular hemorrhage as well. So these are the common causes which comes as probably as a first line to which we should evaluate and try to rule out as early as possible. Rare causes can include, as we discussed in anemia case, like some intra-abdominal bleeds like adrenal hemorrhage, or preterm babies, sometimes they are corticosteroid deficient. So there is an entity called as inotrope resistant and corticoid sensitive shock syndromes, which can be the rare possibilities of acute deterioration on day 4, day 5 in a preterm baby.
So, considering these causes in mind, we have sent the septic screen again. That turned out to be negative. We escalated our respiratory support in the form of ventilation. We ventilated the baby. We stepped up second line of antibiotic. We did 2D code to rule out. There was cardiac function was normal. PDA was very small. But in spite of escalating inotropic support, upgrading antibiotic therapy, upgrading the respiratory support, shock was still persistent. So we added noradrenaline and PCM was also started for the PDA. So Dr. Om Prakash, what do you think are the next possibilities for the babies with normal septic screen and normal cardiac function? Because it seems to be multi-inotropic resistant shock. So what are the possibilities?
So here we have started on dopamine, dopamine, 2D echo was done, even NORAD has also been started, but still there is no response. So I will, as you said rightly, it is a inotrope resistant shock. So we need to try to find out what are the contributing factors. As we know, if there is any component of acid-base imbalance, particularly if there is metabolic acidosis, all these inotropes are not going to help us to improve your blood pressures, but they won't be effective. So we need to look at the blood gases. We look at the metabolic screen in terms of baseline ammonia and lactate. Will also help us to see whether there is underlying metabolic condition that is contributing for this. That is one thing. Second thing, underlying electrolyte imbalance. Presence of hypocalcemia, hypomagnesemia also contribute for there is improper response to your inotrope. So make sure that they are also in a normal range. The sugars are also equally important at this stage. Now, in spite of this, if still the blood pressures are not getting in a normal range, we need to think of, with the background of being a preterm baby, whether there is a deficiency of cortisol, as Dr. Piyush already mentioned. Adrenal bleed is one of the contributing factors. Look at the genitalia, that is also very important. Whenever you are facing a baby with shock, look at the sugar, as I said earlier. CAH can also manifest with this sort of presentation. And then if there is a deficiency of cortisol, it is good to set cortisol levels, that if you are suspecting before you think of starting the cortisol. But in preterm babies, levels are very variable. In fact, we did a review. So we could get Chinese and Korean articles where we saw different levels based on different gestation of these babies. So this baby is a preterm baby. So there is a possibility of low cortisol levels. So we should send the evaluation, and accordingly we can think of start using cortisol. And particularly again in preterm, they do have a transient low levels of low cortisols also. So that can also contribute for a persistence of hypotension, which is not responding to all the inotropes that we use. And interestingly, 2D echo is also normal. So it's not a cardiogenic shock. It is not a septic shock because all your septic screening is negative. So these two common things you have looked for, and you have looked for the loss, acute loss of blood that contributing for the shock. And then you look for the other unusual causes, maybe the metabolic or maybe because of the cortisol deficiency that we can see in preterm babies.
As you correctly said, that septic screen was evaluated. We have sent the metabolic screen that came out to be normal. So we finally sent serum cortisol level, and that turned out to be less than 5 microgram per deciliter. So this baby was started on hydrocortisone, minimal dose, 1 mg per kg per dose, 12 hours apart. And with this, baby showed clinical improvement. So Dr. Piyush, when to send this serum cortisol levels basically? Is there any time bound thing for this for sending this serum cortisol level?
Yeah, so basically there is no well-defined guidelines for when to send serum cortisol level, but as you rightly, Dr. Om Prakash rightly said that since this baby is already on 3 inotropes and there is no evidence of any cardiac and septic screen was all negative. So these are the babies, preterm babies, they can be deficient in cortisol. So that is the right time, probably after the baseline investigation all done. That is the time we should give a chance to cortisol. As we all know, cortisol is a double-edged sword basically. If it is not required and still we are pushing it, it can cause a lot of short-term as well as long-term side effects to the baby. So giving cortisol is a very, very tricky situation, and we should definitely inform the parents as well. As now most of our parents are well educated, they do double check with the Google studies and all. So informing parents also should be a part of normal neonatal care, that we are giving steroids. Thank you.
Yes, very true, sir. So with this steroid therapy, we extubated this baby and we could stop inotropic support on day 8, and we gave hydrocortisone for 3 days. Baby got discharged on day 15 of life. So basically this was late onset glucocorticoid responsive circulatory collapse, as mentioned by both of you, and usually they appear in the first week. And usually SGA babies are more prone, and 5.4 to 6.7% is the incidence. So next thing I want to ask Dr. Piyush, that do antenatal glucocorticoids affect adrenal function of a neonate? Because this is a quite tricky question, because we promote this antenatal steroids even for the early term babies. So what is your?
So yeah, I tried to search this online. A lot of not many studies are there, but yes, 1 or 2 studies did mention that when we are using antenatal steroids, it too crosses to the baby and causes adrenal suppression. But there is no clear-cut black and white guidelines for this, and definitely use of antenatal steroids is looking at the beneficial effect in preterm babies, 24 to 34 weeker babies. We should not withhold the use of antenatal steroid just based on the basis of these 1 or 2 studies. So yes, these are the studies which shows that there is a chances of adrenal suppression, which is still not proven beyond doubt.
Yes, so definitely we recommend this antenatal steroids as a routine recommendation. So take home messages are this late onset glucocorticoid responsive circulatory collapse should be recognized as one of the high risk complications in very low birth weight babies, especially when septic screens, other metabolic screen and cardiac function is normal in these babies. Blood pressure, urine volume should be carefully monitored. Interpretation of serum cortisol, as you said, it is difficult to interpret in preterm babies. And yes, hydrocortisone can be considered, of course, with the discussion with the parents for treatment of such babies. Now let's move to our third case. So this is baby B, which was born to 26-year-old gravida 2 mother with no other antenatal risk factor. This baby delivered vaginally, normal vaginal delivery was there. Baby did not cry immediately after birth, and after giving initial steps of resuscitation, positive pressure ventilation was started for this baby. So they did, as the chest rise was not visible, they did MR SOPA for the baby, and then still there was no response because bag and mask ventilation, positive pressure ventilation was ineffective. Bradycardia was persistent. So they started with the CPR. So I would like to know, Dr. Om, that what could be the possible causes of this ineffective positive pressure ventilation, either by bag and mask or bag and tube.
So this is an emergency which came to us without knocking our doors. There are no any risk factors. Everything is fine. It's getting delivered normally, and suddenly we see a baby who is not breathing, and this does cause a bit of panic to many of us. And then we start bagging, and then after bagging, we realize that maybe after initial few bags that chest is not right. So then we need to do the corrective measures as per as it is mentioned already. MR SOP, all of you must be aware of. Opening the mouth and then reposition your mask and head. Suction the oral cavity if there are any secretions so that the airways are cleared up. And then the next step is increasing the pressure. So see here, pressure is a near to last component before looking at the alternate airways. So we all need to be very careful before we think of increasing the pressure. That is first thing. Second is looking at the alternate airways. Here, second thing what happens is like we start CPR because there was no response to positive pressure ventilation. So the first step of neonatal resuscitation is effective positive pressure ventilation. This is another thing what we tend to do is like bagging or chest compression start for the adrenaline. But if you are missing, if you are not ventilating the lungs, that means you are not going to help the heart pump. So you need to make sure it is respiratory arrest followed by cardiac arrest and not cardiac followed by respiratory arrest in the neonatal baby. Now let's go. What are the contributing factor why chest is not rising? So there may be somewhere some obstruction that is contributing for this. It may be sometimes a thick meconium is there, but here there is no any history of meconium plug or anything like that. Meconium history is not. Meconium is there's no Leica is clear. Then going down, we need to think of whether there are some other pathologies which are contributing. Here they have tried to put, if you are putting a tube, you need to make sure that air entry is equal bilaterally. Sometimes tube is going on only one side and the other side is not expanding. That can also contribute improper chest rise. Or if there is some leakage of air because we are in a panic state and we just want the baby to breathe. So give positive pressure, and many of these bags don't have a manometer. Many of the units don't have a resuscitator with a T-piece where we know how much pressures we are giving. So we do tend to give pressures in the range of 40 plus. And we did an observation where we attach a manometer and we ask all our residents to give positive pressure and see how much pressures they are giving practically to babies. And to your astonishment, the pop-up wall is set at 40s. So till we hear the hissing sound, we tend to give the pressure. So that itself may cause pneumothorax, and that itself can cause the improper chest rise because there is leakage of air is there. There may be some other factors like underlying effusion is there, or a congenital diaphragmatic hernia which may not be noticed antenatally. The scans may not have been done, and they are just coming to you for a delivery. And you tried bag and mask, but there is no chest rise. You hear some different sounds in the chest. Or there may be underlying pulmonary hypoplasia or agenesis of the lungs. So these are the things whenever you face a baby where there is no chest rise. But again, common things commonly, you should make sure that MR SOPA is done properly, airways are taken care of, and don't go for CPR before we make sure you ventilate the lungs. That is what we should keep in mind.
Yeah, as you said correctly, that these are the possible causes of ineffective IPBV. So, say many times, as you said, that whatever pressure we are offering to the baby is much higher, and that leads to air leak like pneumothorax. So, many places like private nursing home or of primary health center where there are resource limited settings are available. So, are there few tests with which they can evaluate that pneumothorax is there in the baby?
We can do a transillumination test. The torch is available at most of the times. And nowadays with the mobiles having light source, I will say that also we can think of using to look at the transillumination. But sometimes the trick part is in a term baby with a thick chest wall and good muscle mass, like this baby has got it's a full-term baby. Sometimes transillumination also fails. If it is a preterm baby with pneumothorax, we can see it very, very, very clearly. Black and white, we can differentiate. So X-ray also should be done where you are in a doubtful situation, what is happening, why there is. So as much practically possible, transillumination is one thing. And then next is, if possible, X-ray, a bedside X-ray will also help you.
Yes, true. So at this point of time, pediatrician contacted a neonatologist where this test was done as it was preterm baby, and chest X-ray was done suggestive of bilateral pneumothorax. This was the X-ray where both pneumothorax are seen. So then ICD insertion was done. So basically, this is a place where neonatal resuscitation was done aggressively, bag and mask, ventilation. Many times there is inadequate manpower or trained people are not there, and that leads to a lot of stress to the people who are actually resuscitating. So in simulation, basically we teach them CRM principles. So would you like to highlight about these CRM principles in the resuscitation?
CRM is crisis resource management. This we have learned from aviation industry. Like aviation industry is one of the finest industry. They try to analyze whatever happens in terms of difficulties that they face, and from them what we have learned is major cause of plane crash is communication errors. That is one thing. So if you try to find out these human factors, it is basically the response of a human to a crisis situation. To do error is a human nature. So in a situation of crisis, how we respond, if we keep calm, we try to analyze and act, or we just do bag and mass and then cause a pneumothorax, that is how it is going to differentiate how the outcome is. So we have to use the technical and non-technical skill to make sure that we are improving our performance, and we need to make sure all our patients are safe. And this is adapted initially in the anesthesia, and the same principle of CRM that we apply in the neonatal resuscitation also. So what are these principles that we look in this CRM? So we have got anticipation and plan of action. So whenever we are going for a delivery, as I said, the emergencies come with it without knocking doors. So you should anticipate like there is possibility. So make sure that I check all the things, whatever is required for me. So we should know your environment, know your personnel who are there with you, with whom you are going to work. That is very important. What the companion can do, what his capabilities are, and then go to the equipment. That is the next step. Third step is equipment. So first two things are very important: where we are working, with whom we are working. Then we need to analyze the available information. There may be some antenatal risk factors. There may be IUGR babies, twin babies, that we need to analyze, and then we need to allocate our attention accordingly at the time of need, what we are going to act in what states of manner. Okay. Then we should be aware what are our resources. Like this pediatrician connected with us in the time of need, he was aware that if there is need, we can have some backup persons in the background. That also helps a lot. Then using cognitive aids, this point I will be focusing a lot. All of us need to make sure that we have got the NRP chart which is stuck on the wall where we are doing resuscitation. Keep it in mind that in the time of crisis, you don't remember like what is the next step or what I should do now. Here also we started CPR before we make sure we inflated the lungs. So that will be avoided if you have got a cognitive aids like a flowcharts, algorithms, which will help you to manage in case of crisis. Communication effectively, a closed loop communication is very vital part. We know many times we just say give adrenaline, we don't know who has given adrenaline, how much adrenaline has been given. So So that communicate effectively, should have a closed loop cycle, give adrenaline this much to, and then you specify the person. You tell the clearly tell the name of the person, Mr. This, you give adrenaline this much, and then the person should give us answer back, this much adrenaline given at this time, and then a bolus also, a flush also is given immediately after that. This is how we can manage the situation of crisis with the available resources. And another thing which we tend to forget, in fact, I will say, we have got only 2 hands that all of us we need to remember. So in case of need, we need to call for help. So we need to have 4 hands or 6 hands, because if you are doing an active resuscitation, we need an umbilical line, so you need to prepare adrenaline. So many things are happening. So that a leader is, I will say, maybe an actively involved leader, or maybe a passively overlooking with the eagle's eye at everything. So both leaderships are fine, but we need to make sure we are following the principle of CRA. So now in this case, I'll go back. So here at a primary place where we noted that the transillumination is showing pneumothorax is there, the X-ray is showing pneumothorax is there. ICD may not be available at many places, or we don't want to wait for the baby to be transferred to tertiary care and then do the ICD there. We have got a bedside things, a cannula, 22 gauge cannula is there. With that, we can do an immediate thoracosynthesis and drain out the pneumothorax and keep underwater seal by the time baby is transferred to the place, so that we are managing the crisis with the available resources. And putting a needle is not a difficult task. It is not going to cause, you can put in second space mid-clavicular, or we are putting in the axillary, anterior axillary, you can put in the fourth space. And it may not require putting simple cannula, and remove the sharp part of the cannula, keep the outer coating, the cannula part, and then connect it to the IV fluid. Connections are there. We just connected that to an underwater seal. Don't give IV fluids to that. Obviously, it is, we want to drain out the air. So this is how we can use the resources and get a good, safe outcome, so that this baby is transported to a tertiary care with a good, effective, positive pressure ventilation happening to the baby.
Yes, yes. As you correctly said, same thing was done with the help of neonatologist in this patient, and then that patient was transferred to tertiary care and ICU. So there, an ICU team gave IV boluses, perfusion improved, then ICD insertion was already done, and perfusion got improved. Then on ventilator setting, post ICD, they went down. Chest X-ray has shown expansion, and baby got successfully extubated on day 3 of life, with ICD removal was possible on day 4. So this is the picture post extubation, and second is post ICD removal. So baby remained stable for respiratory support for the rest part in that ICU. But there was one more thing which happened to the baby, and that was baby had cyclical moments at 4 hours of life with severe metabolic acidosis. So this baby was a case of perinatal asphyxia. So Dr. Piyush, I would like to know that in case of perinatal asphyxia, or in case of high-risk newborns or high-risk pregnancy, do you prefer to send cord ABGs? And if yes, what is the method of collection of such ABGs? Because as residents are there and many people, they are not aware that how exactly this cord ABG is to be collected.
Yeah, so cord ABG collection, there are 2 types of cord ABGs. One is a routine cord ABG, where there are certain institute and certain guidelines which say that you collect cord ABG for each and every baby. Advantage being it helps us as to understand whether there is a perinatal depression or not. Sometimes it is not picked during antenatal monitoring. And most of the places, most of the institutes follow the selective ABG sampling, where if there is a fetal distress or perinatal event is there, then only they will do a cord ABG. So obviously in a setting, most of the Indian settings, selective cord ABG is a better option to offer to the baby. And there is a typical method we should follow, because most of the residents I've seen, they just put needle anywhere and they start collecting the blood. So we should understand the basic physiology, that a cord, umbilical cord, has 3 vessels. One is a vein. So vein is a very large and a thin walled, and the most prominently looking vessel is a vein, obviously. So all the residents are more tempted to put needle in that large vein. But always remember, vein here is carrying a good oxygenated blood from mother to baby. So if you collect blood gas from that vein, it may not show the actual metabolic status of the baby. So we should try to identify the arteries. So there are two arteries, spiral, thick-walled and thin lumen. So it is more difficult to collect blood gas from collect sample from these arteries, but we should develop a habit of collecting blood from these arteries. Ideal way is to clamp the cord on the two sides, like a 20 centimeter segment is recommended immediately after birth. Whenever we are starting resuscitation, ask somebody to put two clamps 20 centimeter apart, then try to take samples from that clamped in between those two clamped portion, identify the arteries, and obviously we should keep ready the heparinized syringes, so that there is no rush to heparinize it later on. And immediately after blood collection, remove all the air bubbles. After collection, we can keep it in room temperature for say 30 minutes. If we feel there is a further delay, we can keep it in ice also. So three important things for cord ABG. Try to collect it as early as possible. Put two clamps around 15 to 20 centimeter apart. Try to identify arteries, two arteries, spiral arteries, which are thick and small lumen. And if there is any confusion, the other school of thought is to take a paired sample. Paired sample means they will collect two samples. One is obviously from the vein, which is easily visible, large size, and the other sample from the artery. And they run the blood gas on both the samples. And if they note a difference of more than, the pH difference is more than 0.02 and the PCO2 difference more than 3.75, then it is considered as a different. One sample is considered from artery and one is from vein. And arterial sample will have a lower pH and a higher CO2. So the sample which has a higher CO2, lower pH is considered as arterial sample, and all the calculation should be done based on that. So
yes, very well said, Dr. Piyush. EEG was done, which was suggestive of encephalopathy, and as baby was fitting into criteria of therapeutic hypothermia, so it was started for the baby with the target temperature of 33.5 centigrade. So Dr. Om, would you like to highlight the criteria for therapeutic hypothermia? Because it is the first line mentioned in the books when we treat the perinatal asphyxia patients. So therapeutic hypothermia is recommended. It is strongly recommended. So what are the criteria for choosing such babies?
In Western countries, therapeutic hypothermia is very well proven. In fact, if you review, I was part of this recruitment team of TOBI trial, in fact, when I was in UK in 2010-11. So we tried to look at the number of babies required to treat for therapeutic hypothermia to get a benefit. So it was as low as, like, at some centers we got 6 babies and some centers had 9 babies. So I will say the number needed to treat in case of moderate to severe asphyxias for a good outcome with the help of therapeutic hypothermia is quite low. So it is a good standard of care. The controversy we are going to discuss maybe at the end about the therapeutic hypothermia. So there are criteria that we need to understand before we think of starting babies on hypothermia. So baby should be near term, more than 36 weeks. That is the first thing. Second, there are criteria A, B, and C. So first, A is it should be one of the following in terms of a low Apgar score of less than 5 at 10 minutes. Baby requiring positive pressure ventilation for at the end of 10 minutes. The cord blood pH, which has been discussed very well, showing pH of less than 7. But if you are finding difficult to cord blood gas, I will say the first hour of life indirectly reflect the in utero insult or during perinatal transition baby has got. So if you are finding difficult cord blood, you can take a baby's blood gas within 1 hour of life. That pH, if also is showing pH of less than 7.7, that also reflects there is component of severe asphyxia. Or look at the blood base deficit. If it is more than 16, So these out of these 4, if one criteria is there, and then subsequently in second criteria, there are signs of encephalopathy. So basically, there is a state of altered consciousness, altered sensorium is there. That means there is some insult to the brain. It may be tonal abnormalities, abnormal reflexes, clinically seizure activity, or poor sucking reflexes. That is second criteria. And third is, if you have got a bedside EEG called as an amplitude integrated EEG or cerebral function monitor, you can look at that and see whether there is underlying signs of encephalopathy. So you fulfill all these criteria to decide whether baby can be started on hypothermia or not. So that is one thing. Now, when can we start hypothermia? There are different trials coming up, early or late, but what has been proven and time tested so far is if you start hypothermia before 6 hours of life, that is going to be most effective. In a places in like Indian scenarios, many a times these babies come from a distant places. But I will say still need to be careful because the outcomes are not showing very promising if you are starting at more than 6 hours of life. What is the target temperature that we'll be keeping for these babies when we are doing therapeutic hypothermia? So 33 to 34 with the average of 33.5, and it should be the Richter temperature, that is a core temperature, that is going to be maintained in the range. Make sure we are not causing fluctuations in the temperature. Fluctuations in the temperatures are more dangerous for these babies rather than maintaining euthermia. If you don't have the facilities for doing therapeutic hypothermia, don't do passive cooling. We hear colleagues using fan and AC and switching off the warmer to maintain the temperature. That is not going to be helpful because you are going to make more fluctuations in the temperature, and that is going to cause more damage to the baby. So duration of hypothermia will be for 72 hours, and after 72 hours, we start rewarming. The phase of rewarming is very critical and very important. That time we need to warm the baby slowly, 0.5 degrees Celsius every hourly. It may take 8 to 12 hours for the baby to get warmed. Make sure we are monitoring these babies very closely during this time frame because there is high chances of seizures during this phase. So if there's any time baby showing some abnormal signs symptoms, we may have to slow down the phase of rewarm. Okay. So in this baby, we saw there was a component of metabolic acidosis with base excess of more than -16, and baby has got some neurological, and EEG was also showing there is a decreased background activities, was fitting into the therapeutic hypothermia criteria. We started the hypothermia at 6 hours of life, and which we continued for 72 hours.
Yeah, then baby has shown improvement in the acidosis. So eventually removing was started after 3 days, and baby got clinically improved, and MRI brain was also done on day 6 of life, which showed normal supratentorial neuroparenchyma without any acute infarct with hemorrhages in the cerebellum. So baby got discharged, such a critical baby who required CPR and bilateral pneumothorax was there, who discharged on day 8 of life. Baby was hemodynamically stable, and on follow-up baby is good. But as I would like to ask you one question, Dr. Om Prakash, that in resource limited setting where this therapeutic hypothermia is not available, where the EEG bedside EEG is not available, where manpower is less, because if therapeutic hypothermia we start, we need more nurses to do the proper monitoring, to take the regular temperatures. So in this condition, so still it has to be recommended, because recently there has been studies which has recently published Helix studies. So they say that this therapeutic hypothermia in resource limited setting has a guided use. So what is your opinion about this?
So Helix trial, which was published recently, that showed that therapeutic hypothermia is not very effective in resource restricted countries. Like they tried in Bangladesh, Sri Lanka, and Indian scenario. They tried to train the people about how to use therapeutic hypothermia, how to monitor the babies, what are the side effects that they will be looking when they are doing hypothermia. And unfortunately, the outcome is not showing promising. So what does that tells us? That tells us that we need to be careful when we are thinking of doing hypothermia if you don't have all the facilities and the trainings available. Many times, as I said, people use passive cooling. using a fan or maybe some ice packs or maybe switching off the warmer and trying to cool the babies. But that is going to cause more harm. And when we are doing hypothermia, the set of babies that we select is also very important. See, in Indian scenario, we do get a lot of IEGR babies who may be 36 weeks, 38 weeks. So these babies, hypophagia may respond in a different way than what we get in a typical Western environment, a good size, healthy babies, well-grown babies. So the response may be different. That is second thing. Third is, if you are not trained for hypothermia, you are going to cause more harm in terms of more problems. Like one of the commonest thing that we face whenever we start hypothermia is babies having hypotension, babies having pulmonary hypertension, babies having hypotension, systemic hypotension and pulmonary hypertension. They do have thrombocytopenias, they do have bleeding tendencies, they get fat necrosis. So all these things you need to be trained to manage well before you think of doing therapeutic hypothermias. Feeding is another component which I want to mention here, that even if babies on therapeutic hypothermias, we can start feeding, and if baby is hemodynamically stable, we can go on top full feeds. So these things are the contributing factors why the Helix trial is showing us that the outcomes are not very good. But it is something, paracetamol works when we go to West, and it doesn't work when you are in a resource limited setting, maybe India. I won't say India is a resource limited setting, because I must tell you here that what we used to practice there, we are practicing here in the same level, in the same quality and standards at many of the places. So what is required is a proper training, a proper selection of cases, a proper monitoring of the cases, and then automatically the outcome will be also reflected in the same way.
Thank you, Dr. Om. So this is the end of our 3 interesting cases. Dr. Satish.
Dr. Sheetal, regarding this resource limited settings, if you are really stuck in a certain situation where you really don't have machine to cool the baby and the parents are not at all affording, at least inform them, take them in writing that this is a treatment option available in some nearby center, private center, or whatever government centers, so that they don't come back to you after 2 years with a neurologically handicapped child and then they say that we were not at all informed about this treatment modality. So always inform them that we are in a setting where this facility is not there. If you want, we can shift to a nearby facility, but if still they don't want to go, then take it in writing. That's medico-legally, that's very important.
I was talking to one of our residents.
It's medico-legally valid.
So after the Helix trial outcomes are there, many of these centers just stop cooling, So that is another scenario. As I said, we should, think and then act. Whether if you are trained, then you should think about it seriously, since we have got enough data so far. Yeah.
So court of law will always see the evidences which were there till the time till the death, like we are practicing in 2022. If by chance if some court case happens, the court of law will see the evidences available till 2022. So if till 2022 there are enough evidences, and as of now there are more studies which say that it is beneficial and hardly 1 or 2 studies which say that it is not beneficial. So we should follow the whatever the literature says and try to follow that. That's very
just important. To add in the list, I was just discussing with my colleagues outside. So they are thinking of hypothermia extending the duration in terms of not just 6 hours, even if you start before 24 hours, that is one thing. Second, they are thinking of hypothermia in mild asphyxia. So far what we have got is moderate to severe asphyxia. Now it is coming to the mild asphyxia, because even in case of mild asphyxia, 30 to 40% of these babies are noted to have some difficulties, maybe very fine deficits like educational difficulties and all that things. So that is what they are looking forward for. So again, lot many things are in process, particularly in relation to therapeutic hypothermia, in relation to the HI management. But yes, different countries have got a different rules, regulations. So we should at least do the standard of care, what is there available with us, rather than doing harm. If that is the basic principle, we should try to give our best and get a good outcomes for babies.
Yes.
Yeah, Satish is there.
Yeah. So our case discussion got over, and thank you panelists for such a wonderful discussion. So that really added to our knowledge today.
So then, general questions from the pediatrician side of you will be the care of preterm. This is the week which is going off like a household care of the newborn in urban areas. That is a theme now. So some questions were from our side, ki how to tackle like a 2 kg child discharge, 1.5 kg child discharge at home. Then how we counsel them about their feeding, their care, bathing, and then oil massage or something like that. That what the people are interested in. That question was from one my mind actually. So if you share, you can clarify on that.
So preterm babies, 2 kg is a classical case where they don't require too much of hospital care. So these babies are will be more better at home care. But since it's less than 2.5 kg, I would suggest the TABC rule, like temperature, airway, breathing, and circulation. So we must teach the parents, most important, to maintain temperature. So for that, they can have a look at the baby's color, fingers, and soles. If the baby soles and all looks nice and pink, that means baby is thermodynamically stable. If the color appears pale and blue colored, then explain that probably baby is feeling cold. So they need to increase the temperature by either switching off the fan, or in case some part of Maharashtra or the northern India may have cold waves. So there they can use the room heaters to maintain temperature. Then regarding most important part will be the nutrition. So even in a preterm baby, best milk is still the mother's milk. If a 2 kg baby, their sucking is good and mother's milk supply is good, then we should promote exclusive breastfeed. No need to add any supplements for a 2 kg baby. And in case baby showing hunger signs, not gaining weight, then only preterm formula milks, which are easily available nowadays, we can advise them. Obviously, avoid bottle feeding for obvious reasons. And then last but not the least is the prevention from the infection. So general hygiene that is required. So good hand washing, mask etiquettes, especially after COVID, everybody is aware about use of masks. So we should keep promoting to the family. If anybody is having cough, cold symptoms, they should use mask while handling the baby. And proper vaccination. 2 kg baby can have all the vaccinations. So we should give them a proper treatment vaccination chart to avail all the vaccines. So that's how we can explain them about the care of a preterm baby. Regarding massaging and bathing, no black and white guideline, but I usually wait till 2.5 kilos before starting massage and proper bath. Some pediatricians may be okay with 2.2 or 2.3 kg also. So no black and white guideline, but yes, better wait till 2.5 kilo. That's it.
Thank you very much. And what you have mentioned about the vaccination, like DPT and also preterms which are to 1 kg or 1.2 kg, then they become like around 2.8 or 2.7 kg around 1.5 months. Then we can give them the vaccination, what we are supposed to give.
Yeah. So any preterm babies, we can give vaccination as per schedule if they are hemodynamically stable. Obviously, if they are critically sick inside NICU, we tend to defer it. But relatively stable babies, they can have all the vaccine except for hepatitis B, which they say the uptake is not very good below 2 kg. So hepatitis B, we can wait till 2 kilos, or if you are giving at birth in a preterm baby, you have to give another 3 more doses, which is happening nowadays. Like we have 6-in-1 vaccine. So even if we give 0 dose at less than 2 kg, you ensure that baby receives another 3 doses at 0.16 or whatever 6, 10, 14 schedule. So total 4 doses in a preterm baby should be good enough. Or if you want to give just 3 doses, then better defer the first dose till 2 kilos. Just and that's valid for only for hepatitis B. Rest all vaccine you can follow as per the chronological age. No problem in that.
Okay, one question was there in chat box on the CPAP, when we can start the feeds.
So feeding, whether you are on CPAP, whether you are on a ventilator or hypothermia, initiate feeding faster. Even the volume of feeds, that is another important thing which has been studied extensively. Whether giving higher volumes increases the risk of NEC in the babies. So answer is no. You can start a good volume of feeds for small preterm babies who are hemodynamically stable. But if they are extremely preterm babies, start with trophic feeds, minimal enteral nutrition, MEN what we say. So there are no contraindications for starting feeding unless baby is very unstable hemodynamically. So we can start feeding for babies who are on CPAP, and we can go up to full feeds on CPAP. And just one more thing I want to add, babies who are on CPAP, on ventilator, they should be given KMC. That is another important thing, that we tend to avoid handling of the babies who are on CPAP or ventilator. So giving KMC help a lot for these babies. For CPAP belly also, the chances will be less. If you are giving, burping indirectly when you are doing KMC, that will help a lot for mother also to increase the milk production. The transfer of the healthy bacteria happens, the risk of sepsis decreases, you can have early discharges. So all these things are very important.
So nursing staff is basically apprehensive about sometimes about CPAP belly. So as Dr. Om Prakash said, if we are giving KMC, that will indirectly reduce the CPAP belly as well. And just that feeding tube, you can keep it open. If baby is on RT feeds, you just keep the feeding tube open to reduce the CPAP belly. Otherwise, there is no harm in starting feeds and increasing feeds on CPAP.
I think all the questions are really were taken now. Sheetal, you want to ask any question?
No.
Okay. So from IIP Navi Mumbai and MGM Hospital, I would like to thank all the panelists for their wonderful, I would say, kind of a clarification on each and every aspect of the newborn care as well as NSU cases, and definitely a moderator who has taken us a very well journey of the cases where we have learned so many new things also. And definitely I would like to thank our mentor, Dr. Rajesh Rai, for this on this occasion. He has in his busy schedule also he could make it possible. So I'm really thankful to Dr. Rajesh Rai sir and our president, Dr. Jitendra Gawane, and all our other team, Dr. Teja, Dr. Mangai, Dr. Vikram, who has given a relentless service, selfless service to the Navi Mumbai IIP to take us routine webinars and other lectures. Thank you very much, and thanks panelists again and moderator. Thank you very much.
Thank you, sir.
Good night.
Good night.
Thank you.